Okay. Okay. This patient who drowned has evidence of hypoxic ischemic injury, hypoxic ischemic brain injury, no response to painful stimuli in the absence of sedation, accompanying by hypertension and bradycardia. This presentation is this presentation is concerning for severely increased. Can you hear me? Okay. This presentation is concerning for severely increased ICP, hypoxic ischemic brain injury occurs with drowning and cardiac arrest. Drowning and cardiac arrest can cause neuronal cell death within minutes. Within widespread neuronal necrosis that leads to cerebral edema, which increases ICP and compresses small arteriole, decrease cerebral blood flow. The classic hemodynamic response to acutely increased ICP, Cushing reflex to restore the cerebral perfusion, hypertension, bradycardia. Okay, hypertension is the sympathetic nervous system activated to increase the systemic blood pressure to maintain cerebral perfusion pressure. Mean arterial pressure minus ICP equal to cerebral perfusion pressure. And bradycardia. Hypertension may stimulate baroreceptor in the carotid artery and aortic arch, triggering a parasympathetic response that induced bradycardia. When accompanying irregular respiration, when accompanied by irregular respiration which occur due to impaired brainstem function, may be masked in mechanically ventilated patient. This is called Cushing triad. Cushing triad is a poor prognostic sign and often indicates cerebral herniation is imminent. Okay. Okay. This elderly patient with fever cough. This elderly patient with fever, cough. Wait, I'm coming. Hello? Hello? Okay, I'm reading the explanation. These elderly patient with fever, cough, tachypnea, leukocytosis, and chest X-ray evidence of lower infiltrate According according to the most recent guideline published by the Social Infectious Disease Society of America, pneumonia is classified as community acquired, develops in non-hospitalized setting, hospital acquired develops more than 48 hours after admission to the hospital, and ventilator acquired develops more than 48 hours after endotracheal intubation. Healthcare Healthcare associated pneumonia is no longer active designation. Healthcare associated pneumonia is no longer active designation for pneumonia as it poorly predicts those at risk factor for multi-drug resistance organism. As this patient developed pneumonia while residing at an assisted living facility non-hospital setting. She has community acquired pneumonia. The most common cause of community acquired pneumonia is streptococcus pneumoniae. The organism is acquired by aerosol inhalation and colonizes the nasopharynx. The most patients remain asymptomatic and clear. Most patients remain asymptomatic and clear the inoculation within 4 to 6 weeks. However, those with aggressive serotypes and certain underlying risk factor age more than 65 and immunosuppression are more likely to develop invasive disease, pneumonia, meningitis, endocarditis. Okay, option A, look at the option A. Anaerobic lung infection most commonly occur in individuals with alcoholism and dysphagia, although dependent on the portion of the lung, right lower lobe is often affected. Most patients have foul smelling sputum and symptoms that progress over 1 to 2 weeks. However, rapid onset illness and lack of aspiration risk factor makes anaerobic infection less likely. Next. Okay, these patients several risk factors for venous thromboembolic disease. Patients with multiple signs and symptoms tachycardia, dyspnea, tachypnea, hypoxemia. Tachycardia, dyspnea, tachypnea, hypoxemia suggest an acute pulmonary embolism. Both surgery and the cancer are independent risk factor of pulmonary embolism, and large intra-abdominal surgeries for cancer resection, hemicolectomy, have an greater risk of hemicolectomy. Mm, okay. These patients' Wells criteria is best classified as 7, 1.5 centimeter, 1.5 points for tachycardia, 1.5 for surgery, 1.5 for tachycardia, 1.5 points for surgery, 1 points for cancer, and 3 points for PE being more likely than other diagnoses, indicating likely pretest probability of the pulmonary embolism. In such patients, CT pulmonary angiography is the initial diagnostic test of choice due to the high diagnostic accuracy. Ventilation perfusion. Ventilation perfusion scan is an alternative option in patients unable to receive IV contrast due to renal dysfunction or allergy. Therapeutic dose as opposed to prophylactic dose. Low molecular weight heparin, enoxaparin, dalteparin is often preferred treatment for acute pulmonary embolism in cancer patients due to possible increased risk of malignancy-related bleeding with direct oral anticoagulant rivaroxaban. Okay, look at the Wells score. Clinical signs of the DVT 3 points, alternate diagnosis less likely than PE 3 points. So 3 points from alternate diagnosis less likely than the PE, 1.5 previous PE or DVT, heart rate more than 100, and recent surgery or immobilization. 1 point for hemoptysis and cancer. So less than 4 PE unlikely and 4 or more PE likely. Okay, next. Yes. Small focus. Lungs, knee, kidney, immune system, is it basement membrane disease like good pasture, lungs and kidney? Nothing fits with this scenario. Good, uh, good pasture looks like okay. This patient renal and pulmonary findings. This patient renal and pulmonary findings suggest a diagnosis of antiglomerular basement membrane (anti-GBM) disease, previously known as good pasture syndrome, a condition common in young adult male. A condition common in young adult males. Renal finding is anti-GBM disease. Anti-GBM disease include nephritic range of proteinuria less than 3.5 gram per day, acute renal failure, and urinary sediment with dysmorphic red cell and red blood cell cast. Pulmonary finding include shortness of breath, cough, hemoptysis caused by pulmonary. Systemic symptom, fever, weight loss, arthalgia are uncommon. The underlying cause is formation of antibody to the alpha 3 chain diphosphorylation, a protein expressed most strongly in the glomerular and the alveolar membrane. Renal biopsy demonstrating linear IgG deposition along the glomerular basement membrane on immunofluorescence is diagnostic. Yes. Is it due to MTX, drug induced acute lung injury, or can I say methotrexate? Okay. The patient is taking methotrexate for rheumatoid arthritis, now has exertional dyspnea, hypoxemia, and pulmonary infiltrate with potential fibrosis, reticular thickening. I think like we are becoming old. That's why we are, our sound is getting lower and lower day by day. No, no, I can hear you. I'm just saying. Okay. Okay, microbiologic workup is negative for infection. In this context, methotrexate lung injury, aka MTX pneumonitis, become the primary diagnostic consideration. MTX lung injury is idiosyncratic, not dose-dependent reaction. The mechanism is akin to hypersensitivity pneumonitis with granulomatous lymphocytic lung inflammation. It manifests with uh, it manifests with often overlying patterns including pulmonary fibrosis, reticulation, honeycombing, honeycomb changes. There is no specific diagnostic test for MTX pneumonitis. Infection must be excluded first, often through bronchoalveolar lavage. Empiric antimicrobials are often administered while awaiting culture data. Bronchoalveolar lavage fluid typically demonstrate lymphocytic pleocytosis, a finding consistent with hypersensitivity. A provisional diagnosis is made when MTX cessation trial leads to clinical improvement. Systemic corticosteroids are sometimes indicated in if respiratory status not improve with MTX cessation. Okay. Yes. He has no smoking history. And is it adenocarcinoma? This patient has long-standing cough, hemoptysis, large irregular pulmonary nodule, raise strong suspicion of lung cancer. Although smoking is although smoking is the single greatest risk factor for lung cancer in all patients population, 50% women who develop lung cancer are never smokers, generally defined as less than 100 lifetime cigarettes. Risk is increased with exposure to secondhand smoke, radon, and environmental carcinogens, asbestos, chromium, arsenic, or oncogenic viruses. Human papillomavirus, chronic lung disease, or previous chemotherapy and radiotherapy are also increases risk. The most common type of lung cancer is never smokers is adenocarcinoma, which typically arises in the lung periphery. Patients frequently have chest pain or a pleural effusion dyspnea due to erosion of the tumor into the surrounding structure. Hemoptysis and cough are also frequently occur, particularly as tumor grows. In contrast, patients who smoke most often develop squamous cell carcinoma, mm, which usually occurs in the central portion of the lung rather than the periphery. Next. Is it TB? Yes. He's he's immigrated from, but he's immigrated from endemic area long ago. Maybe. No, may not be. It's TB. Yes. Is it? O- Okay, look at the option C. Healthcare and prison workers. Common in contact with people who have TB more frequently than the general public, but these patients' recent immigration from endemic area is more significant risk factor. 2 years ago, how it is recent, I do not know. TB is a wonderful disease. My father got TB. My mom got TB. Yes, true. My father got pulmonary TB. My mom got spine TB, and we are left. Yes, it's common. It's common in like in our country, like in Bangladesh. It is very common. Like if you find a case with fever, cough, night sweat, you can easily say that it's TB. You do not need to do X-ray also. Yes, yes. Uh, my father got cured, and Alhamdulillah, my mom got cured too. Yes, in our country, it is like it's like a disease in the Western country. Like a Western country is common like STDs, and in Bangladesh, like TB is like the STD of Bangladesh. Looks like okay. I'm not telling you. Okay. This patient most likely has reactivated tuberculosis. This patient most likely has reactivated tuberculosis. Reactivation of the latent TB. Reactivation of latent TB typically causes apical cavitary lesion seen on chest X-ray. Generally, patients report chronic low-grade fever as well as night sweat, weight loss as seen in this patient. A cough productive of blood tinged sputum is classic, but in the its absence, its absence does not exclude TB. Most TB cases in the US occur in foreign-born individuals who have recently immigrated from endemic area like Mexico, Philippines, China, Vietnam, India, Dominican Republic, and Haiti. The risk is highest for those who have lived less than 5 years. This is important. Who lived in the US less than 5 years with extremely high case rate in the first year after the entry into the US. Even after 5 years, the rates are still up to 10 times higher than US born individuals. Most cases represent reactivation of the latent TB rather than new infection acquired in the local community. As a result, screening and treatment of latent TB is recommended for immigrants and refugees coming to US. Next, Okay, this patient with dyspnea, inspiratory crackles has pulmonary. This patient has dyspnea, inspiratory crackles has pulmonary restriction, and a high resolution CT scan of the chest. High resolution CT scan of the high resolution CT scan of the chest showing a pattern of subpleural honeycombing and reticular opacity, usual UIP. There is no evidence for there is no evidence for underlying connective tissue disease and a normal skin and joint examination and history of relevant exposure asbestos pneumotoxic drug. This patient is most consistent with IPF diagnosed when UIP is present on HI when UIP is present on HRCT and secondary causes of UIP autoimmune disease exposure have been excluded. IPF can be devastating diagnosis. Average survival is 2 to 3 years. Central to IPF pathogenesis is alveolar epithelial injury that is inappropriately repaired by fibrosis scarring. Antifibrotic therapy has revolution, antifibrotic therapy has revolution, revolutionized IPF treatment. These small molecule inhibitors block pro-fibrotic growth factor signaling, transforming growth factor beta, reducing fibroblast proliferation and collagen production. They are approved for IPF patients with diminished lung function, such as reduced forced vital capacity. Antifibrotic drugs slow the rate of FVC decline but cannot restore lung function. Candidates for treatment should be identified early and monitored closely for progression. Okay, yes. Emma, I'm coming. 1 minute. Hello? Yes. Can you hear me? Okay, next. Okay. Yes. This patient with sickle cell disease has signs of right heart failure. Signs of right heart failure. These findings are most likely due to pulmonary hypertension, a severe complication of sickle cell disease associated with increased mortality. Pathogenesis involve chronic intravascular hemolysis, release of free hemoglobin into the plasma, depletes nitric oxide endogenous vasodilator, inducing persistent pulmonary vasoconstriction. It also causes endothelial injury and vascular inflammation, leading to intimal hyperplasia and mediastinal hypertrophy of the pulmonary arteries, vascular remodeling, increased pulmonary vascular resistance, increased PVR to the right ventricular stress and dilatation, signs of right heart congestion, pedal edema, hepatomegaly develops. Elevated right ventricular pressure also increases the intensity of the pulmonary component S2, loud P2, providing the pulmonary artery results in right ventricular failure, decreasing output and impairing left ventricular filling. As a result, cardiac output cannot augment sufficiently during exercise. Symptoms: elevated right ventricular pressure. Elevated right ventricular pressure also increases the intensity of the pulmonic component of S2, loud P2, progressive narrowing of the pulmonary arteries in the right ventricular systolic failure, decreasing the output and impairing the left ventricular filling. As a result, cardiac output augments sufficiently during exercise. Symptoms of pulmonary hypertension can include exertional dyspnea, fatigue, and pre-syncope. Pulmonary function shows normal spirometry but mm, low diffusing capacity of the lung for carbon monoxide DLCO due to loss of vascular bed. Okay, yes, I can't see your screen. Not really. Okay, wait. Now, yes. Okay. Asthma and COPD are lower respiratory tract inflammation, common respiratory tract inflammatory disease characterized by dyspnea, cough, wheezing, and airflow obstruction, decreased peak expiratory flow rate. Asthma is atopic disease with a strong genetic contribution and early life onset. COPD is due to primarily to tobacco and presence later life. In practice, asthma and COPD overlap in age of the onset and clinical manifestation. The diagnosis has this patient has clinical features of both asthma, seasonally episodic symptoms, eczema, family history, and COPD, middle age, or heavy smoking. Asthma and COPD are fundamentally distinguished by the reversibility of the airflow obstruction. Therefore, the best test for discriminating between them is spirometry before and after a short-acting bronchodilator. Patient with asthma show complete reversal. Patient with asthma show complete reversal post bronchodilator FEV1 by FVC more than 70%, and patient with COPD only partial weak reversibility. In advanced COPD, the airflow obstruction becomes fixed. Subjective symptoms relief with a trial of albuterol and is not correlated to the bronchodilator response on spirometry, and therefore is a poor indicator of the diagnosis. Proper distinction is critical for selection of long-term controller therapy. Inhaled corticosteroid is preferred for asthma, whereas inhaled antimuscarinic is preferred for COPD. Okay. Yes. In asthma, uh, in asthma, FVC is normal or decreased. FEV1 is decreased. So FEV1 by FVC ratio, as it is obstructive lung disease, it is decreased. Bronchodilator response is reversible. Chest X-ray normal. DLC is normal or increased. In COPD, FEV1 is decreased. FVC is also normal or decreased. FEV1 by FVC ratio is decreased. Bronchodilator response partially reversible and non-reversible. Chest X-ray, chest X-ray is normal. DLC is normal or decreased. In late stage, COPD, FVC is decreased. FEV1 is decreased. FEV1 by FVC ratio is decreased, usually non-reversible. Hyperinflation or loss of lung markings, and DLC is decreased. Okay. This patient was properly intubated due to myasthenic crisis. Now has intermittent episodes of cough and dyspnea. Several features of his presentation suggest intermittent asthma. Important thermomechanical asthma triggers. Intermittent thermomechanical asthma triggers. Hello? Yes. Okay. This the patient mechanism is likely involves local changes in the blood flow and a neural input that stimulate inflammatory flow, mast cell eosinophil activation, and mediator release by the leukocyte of the bronchial valve. The key inflammatory mediators is the histamine and the leukotrienes, which exert the paracrine effects on the adjacent cell in the airway. Smooth muscles are depolarize and leading to bronchoconstriction, and goblet cell are activated to promote mucus hypersecretion. Okay, my mom is calling. Can you give me uh you do your breakfast, then we can start. My mom is calling for. Okay, okay, bye bye.